right, guys, we're welcome back, and we're talking today about the wonderful drug called Labetalol. And there's a lot of medics that kind of get fearful about giving this guy, and in actuality, I think that it's probably one of the most underused drugs that we should be using a lot more of. However, the reason that we don't use it as much is because, simply putting it, you didn't learn about it, you don't understand what it does, and you don't understand what it does, then you can have problems when you give it in the wrong setting. And let's talk about those wrong settings and how to avoid that. All right. So the other names of this is Trandate and Normodine. Trandate is probably the other one that I see a lot more of, not the Normodine. Again, it's a selective beta blocker. And notice the name here, ALOL, okay? Most of our beta blockers are OLOLs, but this one's ALOL. Let me explain the difference. So the good news is that usually the ALOLs don't affect the heart rate. It affects more of it relaxes the vascular system, okay? Which is why we love it to lower blood pressure, okay? Especially in a hypertensive state. This is the stuff we want to use. If they have a stroke state, we need to get their blood pressure below 180 so we can begin blood clot busting therapies. We can do that, but we have to have, again, so it doesn't have as much effect on the heart. It reduces a little bit of the force of contraction, but it doesn't affect the speed of the heart. So again, it's a selective sympathetic blocker. It's a beta blocker. It does do alpha and beta properties of this, but it's a non-selective beta receptor blocker, okay? The competitive alpha 1, again, it inhibits peripheral vasoconstriction. So in other words, it basically says to the periphery, hey, let's relax a little bit, all right? It causes vasodilation, and it decreases peripheral resistance. And again, somebody in a hypertensive crisis, in other words, their body is squeezed down so hard, man, this stuff is great, okay? And then it prevents the reflex tachycardia, which has a little decrease in the cardiac output. And the key thing is here is a little decrease, okay? So it still gives you a good halfway decent squeeze with this. But again, it reduces it a little bit more. Onset of action, usually within 5 minutes, and then it lasts for about 2 to 6 hours. Again, so, and by the way, if we're using this to prevent more damage from a myocardial infarction, I would say Labetalol is not my first choice of drug that I would go for. We'll talk about that when we hit propranolol and how the OLOLs definitely help protect the heart. The problem is that, again, we're killing force of contraction along with vasodilation. The problem is that in a heart attack situation, I want to decrease that workload for the heart, but I also want to decrease the force pumping and the speed of the heart, which will then protect the heart from further damage, okay? So when do we use this? Again, hypertensive emergencies, man, this is the drug to go to. If they have excessive sympathetic stimulation, your cocaine overdose, methamphetamine overdose, this works great for bringing down their blood pressure. If they have a AAA or a thoracic aneurysm, and we want to keep, or they've got a cerebral aneurysm, and we need to keep that blood pressure down, this is our guy. This is the guy that we really want to use it on, because again, it works on not really the central, it works on the peripheral vascular system, okay? So again, we lower the pressures here, maybe we can keep them there long enough to get them to the hospital. Now, it's a beta blocker. Beta blockers are going to make you dizzy. They're going to make you weak. They're going to give you a headache because it dilates all the vessels. It's going to cause some dizziness. It does decrease the blood pressure, therefore it's going to cause those lovely symptoms. Because it is a beta blocker, it's going to slow the heart rate, okay? And it can actually cause dysrhythmias. It can cause heart blocks, okay? So, again, and the problem is usually somebody pushes it too fast and they push it too much. And the problem is once you give it, you really can't take it back, okay? Again, facial flushing diaphoresis is kind of a normal thing when you get these. Bronchial asthma, again, they're usually on some sort of beta agonist. And so if we kill that beta agonist properties with a beta blocker, they're going to start probably wheezing on us. Really bad idea. If they've got any type of heart any type of heart blocks, guys, we really want to stay away from it, okay? I know that it says a relative one here for second, third degree heart block. I assure you, severe bradycardia, I assure you, we really don't want to be given labetalol. We really don't. If they're in cardiogenic shock or congestive heart failure, really bad idea, okay? Super duper bad idea, all right? You can literally kill the patient. Even though you're trying to lower blood pressure with it, you can cause problems with it. All right, so remember, I kind of said this back when we were talking about the contraindications. Really important to understand that if we kill that beta agonist drugs that we gave them to treat any type of bronchodilator, it's going to make them worse. By the way, if we use this along with nitroglycerin, it's going to really drop the blood pressure. Really drop the blood pressure. If they're on MAOIs, it can cause a severely high blood pressure. Okay, so again, they can interact with those MAOIs and cause major hypertension. All right. Your calcium channel blockers, again, these affects blood pressure might be actually increased because they use those. And then if you are an aminophylline, by the way, is on and all of these guys, the effects of these medications may be blocked. And again, because these are all drugs that interact with the systems. Theophylline, aminophylline are all beta blocking drugs. Okay, or not beta blocking, they're beta agonists. Caffeine causes beta stimulation. So again, it can be increased, especially if the patient smokes still. So understand that these effects can be made worse. The beta blockers they might be blocked, so you push it and it might not even work. Especially the high levels of caffeine. I will tell you the caffeine for sure is one of those. The problem with giving labetalol to a diabetic, it's not that we don't like beta blockers, but it kind of covers up the symptoms of hypoglycemia. So you got to really make sure that you're checking that blood sugar on these guys. It increases the pulse rate and blood pressure, and it can make the hypoglycemia last longer. So you got to be careful with it. If you're given labetalol, if you're given any beta blocker, you got to have them on a monitor, preferably a 12 lead. Blood pressure is every 5 minutes. Matter of fact, if you have an A line, that's even better. Again, pulse rate. You got to continuously monitor those guys. Okay. Observe for signs of CHF bradycardia, and it should be administered only in the supine position. I can't stress that one enough, because again, you set this person up, Granny goes, now she's out. Okay. So again, make sure they're laying down with this. One other little note with this: give it slow, give it slow, give it slow, give it slow. Okay, you don't want to push this one just rip roaring, let them have it, right? And then if you're pushing the flush behind it, real slow. Okay, and again, you got to look for signs of congestive heart failure. They're not backing up fluid in the lungs. Make sure that no bradycardia developments. Listen to those lungs. Make sure we're not getting any wheezes. If they're complaining of shortness of breath, I would probably stop that administration. So we got 100 milligrams and 20 mLs. Usually 5 milligrams per milliliter is our dose. Usually 20 to 80 milligrams is what we give, guys. And then if you need to repeat it, another 10 to 40. Back to the statement of give as little as possible on this drug, though. Again, if I weigh 100 kilograms, you're given, again, 25 milligrams is what we would end up giving. But nice and slow on these guys, okay? And the max dose should never be more than 300 milligrams. That is a ton. I've never even come close to ever giving that much. And again, if we're going to infuse it, it's 2 milligrams a minute, and you titrate it to the blood pressure. So you might be picking up a transfer with a Labetalol drip. And if you do have that, again, you really got to watch that blood pressure. Kids, we just don't use it. Don't do it. If you do it, make sure that you got a physician very specifically ordering it. We give this only IV or IO, and again, category C for a pregnancy. Usually, if we're going to lower blood pressure for a pregnant patient, we kind of like the mag sulfate a little bit better than a labetalol push. I have seen where they have used labetalol up in OB, but it's kind of a rare thing. so that's it for Labetalol. Remember, it's an ALOL, right? Doesn't drop the heart rate and the force of contraction, but remember, it kind of stays away from the heart rate. So the ALOL, stay away from the heart rate. It kind of keeps that constant. All right, I'll see you guys on the next one.